Our next speaker is one of the supporter of Shams from the first day. He has written the chapter on cardiovascular complication of hypertension in 2004. Dr. Hassan Chamsi Pasha. I always enjoy his talks in Arabic as well as in English. He's an excellent speaker in both languages. He's a consultant clinical cardiologist at King Fahd Military Hospital. He is thankfully replacing the announced speaker who is the president of the European Society of Hypertension, who apologized for personal reasons. Thank you very much.
Thank you. بسم الله الرحمن الرحيم والصلاة والسلام على سيد الخلق والمرسلين. First of all, excuse my voice. I will just actually put a declaration. I took the flu vaccine and the following day I ended with this. But that's not against the flu vaccine. I will still advise it and recommend it to everybody, even outside hypertension. Now, I think you heard actually a lot about hypertension guidelines and figures. My advice before I start, forget about all these figures. Remember one thing is treat your patient properly and bring his blood pressure according to one guideline, because I think it is confusing. If you go by all guidelines, honestly, it is nowadays becoming very confusing issue. So take one guideline, whatever you like, and stick to it. The most important thing, as I said, bring the blood pressure to a good, reasonable level. We know from studies worldwide that 50% of patients have not reached 140/90 up till now. So I think this is a message to start. Now, Dr. Abdulhamid Jazallah Khair started with the European. He told you, I think, everything about it, but I will just again sum it up and just stress some points. So, first of all, I think this doesn't work there, the pointer, I think. Let's see if this works. Point to this here. Yes. I think it's a bit difficult. I will stick there. Anyway, what is normal according to the European guidelines, which were published 3 months ago? That systolic 120 to 129, as you heard, over 80 to 84. And high normal, 130 to 139, over 85 to 89. So remember, very small figures, not too many figures. Grade 1 hypertension has not changed in the European guidelines as grade 2, grade 3 hypertension. Okay, let's go forward. Now, Dr. Hamid mentioned actually these devices and the stress on home blood pressure monitoring. Believe me, if I first thing you ask the patient, if he check his blood pressure by the wrist sphygmomanometer, let him throw it in the bin, because it's not reliable. I use it myself more than once. I got more than one device, and they are not reliable. Go always by something solid, which is the arm blood pressure. It's very cheap, 150 riyals, you get very good, reliable sphygmomanometer. And that's important. Now, the blood pressure measurement I talked about, actually, the ambulatory blood pressure, it's not available in every hospital. But home blood pressure monitoring, it can be used everywhere. And ask your patient to have a diary and get his blood pressure measured and recorded according to the date and time. Now, what is the definition of hypertension in the latest European guidelines? And I believe in this guideline, honestly, this is my personal belief, The American guidelines, unfortunately, I think they have been criticized. And I think this is the latest, which in fact is common sense. Office blood pressure, we're talking about measurement of office blood pressure. 140 over 90 and above, this is hypertension. 140 over 90 and above, this is hypertension. And this corresponds to home blood pressure measurement more than 135 over 85. Now, what about actually the thresholds and targets of antihypertensive drugs? Now, you know, actually, when we talk about very high risk, this is actually the people who got established coronary artery disease. This is the most common. There are others like diabetes with target organ damage or patients with severe chronic kidney disease. Again, these are all very high risk group of patients. Now, you initiate, according to European guidelines, a blood pressure measurement, lowering treatment at the time when, in fact, it is here, the blood pressure, 140 over 140 to 159 over 90 to 99. This is immediate drug therapy after also in lifestyle advice in patients who are very high risk. Now, in grade 2 hypertension, if the blood pressure 160 to 179 over 100 to 109, and grade 3, immediate drug measurement. Drug therapy. Do not wait. Do not waste time. This is very important message. Now, for the threshold, when do we initiate according to the age? Once the patient is 18 to 79, 18 to 79, and the blood pressure 140 over 90 and above, initiate therapy. And this is actually the threshold to start with. You start with aiming at this threshold more than 140 over 90 to start with. Then you want actually to bring it lower to less than 130 over 80. But that is the first aim. And for those who are above 80, as you see it in the purple triangle, once the blood pressure more than 160 over 90. I think this is very reasonable and very logic to start our patient with this. Don't go for targets or thresholds which are unrealistic. This is my belief, and I think this is very common sense. Now, what is the target? Again, target blood pressure, as you heard from Dr. Hamid. If the patients are 18 to 85, the target is less than 130. We start aiming before, initially at 140 over 90, and then go forward to less than 130 over 80. Whether the patient has only hypertension alone, or whether he has hypertension and diabetes, or whether the patient has hypertension and coronary artery disease or stroke, all of them aim at 130 systolic and less than 80 diastolic, and that's to remember. If the patients are between 65 and over 80, I lump them in one target, less than 140 to 130, so a little bit lower. Okay? Now, what about the hypertension treatment? We don't need to overemphasize lifestyle changes. Very important. Even light exercise is very important. If the patient walks, just actually slowly, even slowly, encourage him to do it and to speed up as well. sticking to low salt diet, important, and in addition to the Mediterranean diet. This is in simple. Now, let's start with this. Now, again, the Europeans still put the 5 groups of classes of antihypertensive medications. So ACE inhibitor, ARB, beta blocker, calcium channel blockers, and diuretics. You can use any of these. Preferably, of course, the ACE inhibitor, ARB, and calcium channel blocker in addition to the diuretic. Why? Because they are all shown to be, this is their guidelines, effective reduction in blood pressure and cardiovascular events. Okay? So this is actually the latest. Now, combination therapy is going to be required by most patients as an initial therapy. I think there is a small area now for just monotherapy. I will show you that in a second. Now, beta blockers are combined with any other major drug. These are all class 1 indication. When there is a specific clinical situation like angina, heart failure, post-myocardial infarction, heart rate control, so there is still a place for beta blocker. And the drug combination therapy in a single drug, single capsule, is preferable, but be careful in frail old patients. Frail old patients, be careful with them. Giving them triple therapy in one capsule, it may be hazardous. So be careful with the frail old patients. Now, if the blood pressure is not controlled with 2 drugs, of course, we go for 3-drug combination therapy. This is, again, all I'm talking about class 1 indications. Class 1 indications. Again, if the blood pressure is not controlled with the 3 drugs, then spironolactone. It's a magic drug. Even with the small doses, the guidelines put 25 to 50 milligram, but even if you use 12.5 milligram of aldactone, it is a wonderful drug to add as when you get a case of resistant hypertension. So that's actually important. Now, the combination, of course, of 2 RAS inhibitors, ACE inhibitor, and beta blocker, this is class 3, which is red, so should not be used. Where shall I go with this? This way? Sorry. Okay. Now, what about actually how to initiate therapy? In patients who are uncomplicated hypertension, and most patients with hypertension-mediated organ damage, you will hear this HMOD. There, you see it in the top there. This is hypertension-mediated organ damage. Patient has got cardiac involvement, have got microalbuminuria, and so on. These are organ damage signs. Or these patients who got cerebrovascular disease, diabetes, or peripheral artery disease, initial therapy, ACE inhibitor or ARB, plus calcium channel blocker or diuretic. This is here a class, very simple, and they omitted in here the beta blocker. Because beta blocker, it has its own specific indications. Now, what about monotherapy? Monotherapy is only for low-risk grade 1 hypertension, not for high-risk patient hypertension. And if the blood pressure in elderly patient or frail patients above the age of 80, monotherapy there is indicated. Okay, step 2 is ACE inhibitor or ARB plus calcium channel blocker and diuretic if the first step is not controlling the blood pressure. Very simple. And the step 3, of course, as I mentioned, if the patients have got 3 drugs, you will hear about resistant hypertension in this symposium. If the patients have 3 optimal doses of 3 drugs, then add the spironolactone, as I said, 25 to 50 milligram a day. And that will be wonderful. Beta blocker, I mentioned it for heart failure, angina, post-MI, atrial fibrillation, or younger women contemplating pregnancy. Because you know ACE inhibitors or ARBs are contraindicated in patients contemplating pregnancy. So this is very important. Now, hypertension in specific situations. Again, in patients with hypertension plus coronary artery disease, of course, beta blocker here will come up to the front. So ACE inhibitor or ARB plus beta blocker plus or calcium channel blocker. That's the initial therapy. If the patient is not adequately controlled, then step 2, which is triple combination therapy, and if not controlled, add spironolactone. Very simple algorithm. Now, remember that whenever you give ACE inhibitor or ARB, there is a chance of increasing creatinine, and in fact it is expected, but go up to 30%, and that's in the guidelines. If the creatinine goes above 30%, then think about investigating the patient for underlying cause like renal artery stenosis, etc. So that's very important to think about. Now, what about patients with heart failure and hypertension? Again, it's common sense. ACE inhibitor or ARB plus diuretic plus beta blocker. Very simple, very simple. If step 2, if not controlled, you add another drug, particularly the aldactone or spironolactone, because there is good evidence for it in patients with heart failure. No doubt about it. Now, device-based therapy for hypertension, they are now class 3. That renal denervation, baroreceptor measures, and so on, these are still class 3 indication up till now. There is no strong evidence for them. So now let's sum up what is new and what's changed in the European guidelines. Now, again, the emphasis, as I said, in 2018 on repeated office blood pressure measurement or on out-of-office blood pressure measurement. This is important. And again, for high normal blood pressure, 130 to 139 over 85 to 89, drug therapy may be considered when there is high cardiovascular risk in these patients, very high. Okay. Again, here, for treatment thresholds, for those patients above the age of 65 but up to 80, again, blood pressure therapy is recommended when the systolic blood pressure in the grade 1, 140 to 159. You go for antihypertensive therapy, and the targets, as I mentioned, initial objective, go to below 140 over 90, and with a final target to go to below 130 over 80. Remember only these figures, and I think that is enough, because I think you cannot remember all other figures in this. Okay. Now, again, here the addition of spironolactone in resistant hypertension, they put it as actually a class 1 indication in these patients with resistant hypertension. Now, again, device therapy, they said that it is not recommended for routine treatment at this time of the day. In conclusion, ladies and gentlemen, there is wider use of out-of-office blood pressure measurement. This is recommended. Lifestyle changes recommended for all patients without any question. And initial treatment for most hypertensive patients should be with a combination of 2 drugs, and the guidelines recommend the single pill combination to treat most patients to improve the adherence of therapy and blood pressure control. So this is the bottom line for the management of hypertension. I will stop here and thank you very much indeed for your attention.